Look, I don't want to talk about it until I hear it. Oh, yeah, I don't know. I do. I was asking you to like because it is most dry ingredients.
Good afternoon, everyone. We should be starting here shortly. Just want to remind those that are committee members, if you would please put your name in the chat so we can ensure we capture attendance. If you are a committee member on the phone, if you would unmute yourself and let us know that you are here, and we should begin shortly. Thank you.
This is Kim Dancy. I'm on the phone trying to log in, but I'm listening on the phone first.
Wonderful. Thank you so much for letting me know you're here, Kim. Appreciate it. And Michael, to let you know, I'm waiting for 1 or 2 more committee members, so I'll let you know when we've got a quorum.
Okay, thank you. While everybody's joining, if you have any any amendments to the meeting minutes, you can just have those ready so we can discuss them when we get a quorum. They were sent out about a half hour ago, so if you haven't had a chance to see them, maybe just wanted to point that out to have you take a look at those.
And team, this is Jennifer Brinton. I just can't see where to do the chat thing to say my name, but just here, I'll look at those notes too. Thank you.
Thank you, Jennifer.
Okay, and Michael, so we do have a quorum. So yes, when committee members, I did send them out a little bit late today. So check your email. You should have the meeting minutes and the unwinding report as new attachment for today's meeting. So thank you.
Okay, thanks, Sharon. Welcome everyone to our April MAC meeting. We do want to start out by just clarifying that today is not the public hearing. Sharon had indicated there were several inquiries about being on the agenda today to propose budget requests. That meeting will be next month in our May MAC meeting. And at the bottom of the agenda, you can see that the date and the time will be a little later than we usually meet. We usually meet from 2 to 4 to try and be more accessible to the general public. We'll be having that meeting from 4 to 6 p.m. And if you do know of anyone or you are interested in making a presentation, then we'll ask you to submit a request to Sharon, and then we'll get a queue of presentations set for our May meeting. Are there any questions about that? Okay. And then after we've had a chance to review the presentations, and then we'll plan to vote on a recommended priority in our June meeting. So we've moved the process up 1 month this year compared to what many have been experiencing or comfortable with in previous years. All right, I've had a chance to look through the meeting minutes, and they look like they're what we have experienced last month, but I will open it up for any potential changes or to adopt the minutes if somebody would like to make a motion to do that.
I move to adopt.
Okay, thank you, Jennifer. Do we have a second?
I'll second that. This is Kim.
Okay, Kim made a second. Okay, thank you. All right, and as we usually do, unless somebody opposes, we will assume unanimous support. So we'll just offer a moment for any potential opposition. Okay, thank you. So we will consider the meeting minutes for March to have been approved. Our next item on the agenda, we have a public hearing on the new extended postpartum coverage for pregnant women. So we will turn some time over now to Laura to give us our overview, and then we'll open up a public comment period.
Great, thank you, Michael. So yes, do have another 1115 demonstration waiver amendment to present to you today. Just as a quick reminder, this is an opportunity for the committee and the public to provide feedback and comments prior to our submission of this amendment to CMS. We will be submitting this amendment by June 1st. Today is not the only opportunity to provide comments. We are currently in the 30-day public notice timeframe, which began April 10th and will go through May 10th. So you will be able to submit comments until May 10th through the various ways outlined in the full amendment and on our website. You can find those online. And the website is given on the summary, which I will read in just a second. So as usual, I won't present the whole amendment application, but will instead provide this overview summary. And before going over the summary, I just wanted to note that Senate Bill 133 includes content regarding the creation of a family planning only program for individuals up to 185% of the FPL. So we are running this section of the bill as a separate amendment, just to make everyone aware of that. And the public comment period for that amendment is coming up. It will be May 15th through June 14th. And so I will be presenting that summary along with a few others in next month's meeting. So just to go over the summary here. So this is 12-month extended postpartum coverage. And as mentioned, this is the result from Senate Bill 133, which was run through this year's general session. The bill was titled Modifications to Medicaid Coverage. This amendment seeks authority from the Centers for Medicare and Medicaid Services to provide 12 months of extended Medicaid coverage for certain postpartum women. As far as the eligibility goes, individuals must meet the following eligibility criteria to qualify for the 12-month extended postpartum coverage. And the criteria is that the woman is eligible for Medicaid during her pregnancy, and the woman's pregnancy ends by the way of birth, miscarriage, stillbirth, or an abortion that is permitted under Utah Code, Section 76-78-201. As far as the benefits, there are no changes being proposed to the postpartum benefits provided to eligible individuals under this amendment. Individuals would continue to receive state plan postpartum benefits. And as far as the time frame goes, the state intends to implement the coverage as soon as possible after approval. And as far as the population impacted, we expect approximately 8,400 individuals to be eligible per year if we do receive approval on the amendment. And so as noted, this is the 1115 waiver website where you can find the full amendment. And again, you can also submit your comments through a link on the main page. So I will now open it up for comments. Yes, Stephanie?
Yes, hi. I do have a couple comments that I'd like to share, and I can also submit these in writing. And I'm sorry if I missed this, but did you mention that it does appear that this is going to be, CMS has already said they aren't accepting waivers like this, is that correct?
Well, Jen, do you want to
Sure.
answer that? Yeah, I think that's probably.
Sure. Thanks for the question, Stephanie. CMS has indicated to us that they lean towards a full coverage package, which is as defined underneath the state plan. They have shared with us that they will give our waiver a full review. So we have spoken with them about this. They've said that they do lean towards the full coverage package. That is what they want. And that's why the state plan benefit was designed. But they have committed to give our waiver a full review.
Okay. Okay, thanks for that clarification. Yeah, I'd like to just share a couple comments. Yeah, and I can send these in writing as well. I mean, I would just ask that CMS would reject the waiver so that we can implement the state plan amendment. And I just want to share a couple of reasons as to why I think that the waiver as is not, it's not good policy for Medicaid beneficiaries. and the state plan amendment is a much better fit. And I understand the politics of all of this, but, you know, again, I think it's important to just reflect from a member perspective why I think policies like this can actually create more harm. I think when we think about what this opens up as far as like policing and surveilling and really kind of picking and choosing which non-live birth pregnancy, like the way that a pregnancy can end is right, like through live birth, or there's like a variety of ways that pregnancy can be ended that does not result in live birth. And then that's where we're opening up women to be scrutinized. And how a miscarriage is or isn't defined, whether that does include, oftentimes it includes abortion medication, oftentimes it includes, there's a lot of complexity. And so we're now asking, you know, Medicaid eligibility workers to become, to invade and infringe on the privacy and for many women, a really traumatic part of their life if they've experienced a, you know, pregnancy or fetal loss. And I think it's really harmful to try to erode trust between Medicaid beneficiaries and eligibility workers by creating another way to scrutinize them and to police the decisions that they're making, and to show that the agency doesn't trust, you know, the beneficiaries, you know, decisions, or just the way that they might self-report how their pregnancy ended. And so it's, you know, likely to create like gaps then in which women actually will try to seek this coverage and which women won't, because they don't want to go through, you know, the scrutinous process that is going to be, you know, that would have to be implemented in order to carry out the legislators' you know, decision on how they wanted to change the postpartum coverage. And so I think we need to just go with the state plan amendment. I think that, you know, for anyone who thinks that this would not be a big deal because, you know, Medicaid caseworkers can just, they'll just have it be open-ended, and however people self-report, it's not going to cause any more burden for the women. I think that we have to be cautious with that. I think in the history of, you know, this country, I think, and even just like present day, like the policing and surveilling of poor people, especially poor women, is not, it's not something we should take lightly. In the 60s and 70s, we know that there were midnight raids from caseworkers where they could literally kick down the door of a person on public assistance, and because men were not allowed, because a woman had to live alone to be able to get certain benefits, they would look for things like belts, shirts, men's shoes, and if they found any of those items, they could not only kick the woman off of public assistance, but they could criminalize her. They could charge her with criminal fraud. And, you know, we know that some states use social media surveillance to surveil beneficiaries and determine whether or not they are eligible. And if they can spot fraud, they can charge them with criminal fraud based off of social media posts. Like, there is a lot of surveillance and policing of poor people as it is. And again, we just like don't need to have another option of opening up additional policing and additional surveilling of poor people in this way. I think it could also be harmful for just like the maternal mental health element of having, you know, women who don't want to have to go into detail about their experience if it was a really traumatic stillbirth or whatever it might have been. If they're having to now describe all of this and talk about it with a caseworker, and, you know, the kind of PTSD and traumatizing effects that it could have there. And I think it's just, you know, in my conversations with members of the legislature, I think the only way that policies like this move forward is because they've created this like villainized idea in their head of some person that is going to just like they have this really, I mean, I don't want to actually go into detail of what I was told, but this like really crazy story of what this policy is trying to avoid. And it's ridiculous. And it's just not the way that poor people's lives are like it's a deep misunderstanding of poor people. And again, it's like villainizing you know, truly the least powerful in our society. And so it makes me really angry because Medicaid beneficiaries don't make money off of Medicaid, right? Like, utilizing healthcare is incredibly important when you need it, but we don't make money off of it. And so when we're villainizing the actual beneficiaries, that is one of the factors that's causing some of that mistrust in between beneficiaries and medical institutions and the government, because Medicaid beneficiaries are not treated with trust, respect, and dignity too often, especially when we look at policies like this that are driven by, you know, just politics for the sake of some kind of performance. And I think it's important to make sure that we respect the public servants who want to serve Medicaid beneficiaries, that they don't go into public service because they want to scrutinize and villainize those who are in desperate need of good, high quality health care. And so I also think that it's not respecting them as public servants. And further, I think that, if we're going to be scrutinizing any part of this policy, I think where we need to look is how we ensure that, upon the money that's being paid for the health plans to have 12 months, of covering these beneficiaries, that there is actual appropriate, adequate delivery of healthcare services that, women, these postpartum women desperately need. I have been thinking about, as I've been thinking about this policy, I've been thinking about a beneficiary that I know who had a really traumatic pregnancy, and it made her mental illness much more severe than it ever had been. And she has lost custody of her child. Her mental illness has gotten really severe. She has not gotten really great health care. She hasn't had the best experience on Medicaid. She's lost custody of her kid. Anyway, when you really know these women, you wouldn't, not only would they not be, it would be harder to villainize them, but it would also be harder to just look at the status quo as being acceptable. So we need to do better, including all of the healthcare industry partners. We need to do better to make sure that we're actually delivering high quality, value-based healthcare that meets the needs and actually drives more, a stronger maternal health outcomes. Just being covered is not actually what will deliver higher maternal health outcomes. We really need to make sure that it's also about the delivery and the care being utilized. And lastly, and I'll wrap this up and apologize for the time I'm taking up, but my last comment, I guess, for just anyone that's listening is just that if you have access to people that make political decisions, politicians, elected legislators, and they are villainizing poor people, I encourage you to set the record straight. And if you have a hard time doing that because you don't understand the lived experience of Medicaid beneficiaries, then I encourage you to collaborate better with Medicaid beneficiaries. There were a lot of organizations working on this policy, a lot. And that in the end, the policy that got pushed through is one that, is just, does not really respect the dignity of beneficiaries and is opening them up for more scrutiny, is disappointing from a member perspective, because we need to do better about the way that we talk about and the way that that politicians understand the lived experience of Medicaid beneficiaries. Because if they understood, they wouldn't support a policy like this if they truly understood the lived reality. So anyways, I'll submit this in writing, but I wanted to make a few of those comments today. So thanks for letting me take the time.
Thank you, Stephanie.
Okay, thank you, Stephanie. Are there any other comments on the waiver as proposed and described by Laura? Okay, Jessica.
I just also want to go on record and certainly lift up what Stephanie said. And I agree that CMS should quickly reject the Utah proposal with the carve out as it's currently written, so that Utah can fall back and apply for and implement the full postpartum coverage through the CMS authorized state plan amendment, so that all women eligible for pregnancy coverage could be eligible for the 12-month extended postpartum period. In addition to the, the lived complexities of how pregnancies and the very limited types of abortions that are permitted under Utah code, which in many cases does not cover all maternal indications, and many of those folks would, or fetal indications, and many of those folks would very much benefit from ongoing coverage and care. But I also think that the amount of administrative burden imposed by this waiver as opposed to the state plan amendment feels unnecessary and hard on kind of state resources as well. And so my hope is that this can go through quickly so that we can fall back to a full coverage. Thank you.
Okay, thank you. Anyone else who would like to comment on the proposed waiver amendment? Okay, if anyone has any additional thoughts that come up during the meeting, we'll circle back at the end of the meeting to ask once again for any additional comments to be submitted. Okay, next on our agenda, we have the director's report. So Jen, we'll ask you to start with your report now. Thank you.
Yeah. Thank you, Michael. Hi, everyone. I have several things to walk through with you today and share regarding our updates. I'd like to just walk through, first of all, and start with our PRISM system, which did launch on April 3rd, 2023. This was a many year effort to develop, build, test, and then fully implement the PRISM system, which is really the base program for all of our Medicaid operations. Its successful launch on April 3rd was really rewarding for us. We've had teams in the office working for the last 3 weeks and really supporting the go live efforts. We're pleased to say that with such a large system, we did not experience any system outages or interruptions when we went live. We have been able to send out now 2 cycles of provider payments. Certainly we have things that we are working on, but have not had any serious issues that were unexpected that we have not been able to work through or are currently working through. A couple areas that I want to highlight for the committee is that we have had, while we've invested many months in developing provider training materials and preparing our staff to support providers with this change, there is certainly a learning curve with our 40,000 plus Medicaid providers in using this system. And so we have really built supports around this transition process to help providers know what's needed. First of all, with their own enrollment as a Medicaid provider, we have several standards that are new with regard to being enrolled as a provider in the Medicaid program. They are not necessarily new with regard to what we're asking for, but the way the system works is mandating some elements that have been identified in the past, but are now required in our newer system. And so we are lifting up supports to really bring forth our provider enrollment processes to support providers as they're enrolling. For example, one piece is provider specialty type. And providers in our old system didn't have to designate a specialty type. One thing about being in a newer system is that our system has the capabilities of really designing programs and services around a provider's specialty and subspecialty. And so that is a required element for our new system. So that's one piece, for example, that we are working with our providers on to get them enrolled. Another piece too is provider claims billing. And I'll just give another note that one of the areas that we've seen while we've processed now claims for the last 2 weeks, one of the areas where we're seeing a number of rejections in the claims billing is our old system to our new system went from an older 40-year-old-ish system to one that follows current billing standards. And some of the claims that were submitted without these standards are rejecting. So in order to support our providers who care directly for our members and are really such an essential element to the work we do every single day, we have opened our phone lines and supported phone calls from 7 to 7 for the last 3 weeks. We've also stood up numerous extra trainings and Q&A times for our providers and billers and claim specialists and folks who are submitting prior auths to join these calls and have Q&A times. We've also set up special times with providers too. So we recognize this is going to be a transition, and we want to be part of supporting providers and any Medicaid stakeholder in that transition. So it's really where a lot of our effort is now. I don't want to downplay some of the challenges we have faced when we turned our system on. As it was designed over a number of years, we knew that there were some pieces of it that we would have to fix after go live. And certainly there have been some bumps with our go live where we've had to work through, for example, a delay in providers getting some payments. It took a couple days extra, for example, or 3 days extra for some payments to come through. And so it hasn't been a bump-free process, but it certainly has gone well, and we're happy to be moving forward with this change. We believe it will certainly improve the functioning of our program overall and support where we want to go with regard to being more up to date with our billing and with our management of our operations. I do have a hyperlink that has our PRISM training resources on it. There's a host of resources on this. So for anyone who needs additional supports or training, we do have that, and I will make sure this gets distributed with the materials afterwards. So I want to thank all of you for being part of this process with us as we transition to this program. And thank you for Rachel for your comments, for example, and Stephanie for being the shout out. We know it's not been perfect, but we certainly are in this together and we're here to support you. I want to transition to the next piece to just cover some policy updates that are coming our way. So as we look at our months coming out of legislative session, we have 2 big activities around launching our PRISM system. Jeff Nelson is going to mention and walk through our unwinding activities. But we were also very fortunate coming through our legislative session this year with many exciting enhancements to our program that I wanted to just keep our eyes on as July is fast approaching. And I wanted to highlight some of this work for you today and just go through some pieces that the team is working on. First is a new service for adults, which will expand our autism coverage for individuals who are 21 years of age and older. We currently have comprehensive benefits for individuals with autism who are under 21 years of age. This will expand that same coverage benefit to the adult population. And we will be implementing this on July 1st, 2023. SB 237 for dental hygienists. This further expands the role of dental hygienists who are practicing in a public health setting so that they can have a little bit more flexibility to practice without the direct oversight of a supervision of another dentist or collaborative agreement in certain settings and under certain conditions. So our policy will reflect these changes and will be updated in July. The next is for healthcare professional licensing requirement. This is for to enhance telehealth services from out-of-state providers. where this bill states that a qualified non-resident provider who does hold a healthcare license from a different state may provide telehealth services for an in-state Medicaid member. We do have this on our radar to get our systems set up to be able to support providers enrolling as out-of-state providers, and we will be updating our provider manuals to reflect these changes July 1st. The next item is around annual wellness visits for adults, and this legislature was really important to us as it supports our preventive services, which are one of our priority areas. And specifically, this funding will cover an annual wellness visit for adults. I did specify the codes that will be included in this coverage benefit, CPT codes 99385 to 99387 as an initial visit, and then also some follow-up visits. There will be a quantity limit of 1 visit every 9 months on these codes. We're really excited to have this service opened for July of this year as well. Next is private duty nursing. So there was funding put forth and legislation to expand the services that individuals can receive underneath the private duty nursing benefit. This will do a couple things. First of all, it will extend to allow 24-hour care. Today, I believe it's only to 72 hours, so you can get 24 hours of care, but just for 3 days. This will expand that service out to 14 days of coverage, and it will also help us look at our policy around the acuity grid that helps score a person's acuity, that then designates the number of hours of private duty nursing that individual qualifies for. And we are working to update our acuity grid so it's more aligned with the best practice standards that are in the industry today. So we're also looking forward to updating that coverage. Are there any questions about this policy now? These policies? Okay, great. I'd like to just touch briefly on, I know that Laura already covered our 12 months postpartum waiver amendment that will be submitted by June 1st, and she walked through that with you today, and we appreciate your investment in this and your contributions to this work and your feedback you gave through the public hearing today. The other piece of the public comments today, the other pieces we wanted to just have on your radar that we will be submitting by July 1st will be a waiver, 1115 waivers for family planning services. This will allow individuals to receive comprehensive family planning services for uninsured or underinsured individuals up to 185% of the federal poverty limit. This will be submitted to CMS by July 1st. Next is expansion of our adult dental services to individuals who currently don't have dental services. And this will essentially allow coverage for all adults in our Medicaid program outside of a very small portion to have comprehensive dental services. That will also be submitted by July 1st. Next is an amendment seeking services called chronic condition. We're calling this waiver amendment chronic conditions, which will allow our fee-for-service populations living in rural areas to qualify for support services around chronic condition and disease management. So this allows more comprehensive case management and disease management services for individuals who are living in rural areas. Again, this will be submitted to CMS by July 1st of this year. And last, I wanted to touch on our medically complex children's waiver. While we've been actively enrolling, we've been able to have additional placements from last year's session, and we are still actively enrolling those seats today. We are able to now enroll an additional 190 individuals into this waiver program, taking our enrollment from today from 710 individuals up to 900 individuals. This waiver will also be submitted to CMS by July 1st of this year. And by the way, we have Joe and Brian, who are here on the line as well, who can speak to our current enrollment, which is coming along really nicely to continue to expand the services underneath the medically complex children's waiver. Are there any questions about our waiver updates today? Okay, great. Last but not least, before I finish my portion, is I wanted to just alert this group to the end of the public health emergency, which is officially occurring on May 11th, 2023. We had several flexibilities that were put in place as a result of the public health emergency that we've been in since March of 2020. And I wanted to just highlight some areas that I wanted you to be aware of what's changing with the end of the PHE. First, I'll note again that you're aware that our continuous enrollment requirements did separate from the PHE end date with the Consolidated Appropriations Act. So that is occurring separately. They were at one point very connected. The end of the PHE had to do with unwinding, and with the Consolidated Appropriations Act in December, these actually became separate activities. And so as Jeff covers those, just know that these are all now being undertaken, but certainly under different authority. So under the public health emergency, we had three different types of flexibilities that we had in place. The first is our 1135 waiver, which at the end of the public health emergency, this waiver will expire immediately. I'll just want to compliment that with the 1135, these were a lot of the benefit flexibilities that we had put in place around access. Some of these were the telehealth visits, our quantity limits, our prior authorizations, some of our in-person, again, telehealth in-person requirements. These flexibilities and what's changing at the end of the public health emergency are all detailed in this hyperlinked document, PHE Unwinding Benefit Flexibilities, which is found underneath our Unwinding webpage. And I'll go ahead and put the hyperlink to that in just a minute when I'm done presenting. But really overall, I will say there are modest changes to the flexibilities. These are detailed in this document, but overall we are keeping most of our telehealth flexibilities in place post PHE, and certainly some of the quantity limits and the prior authorization requirements that we removed, we are not going to be putting many of those back in place after the PHE. So I'd refer you to that document, and if you have further questions, certainly should shoot any question you have our way, and we'd be happy to walk through those with you. The benefits under Appendix K do persist for 6 months after the end of the public health emergency. So these flexibilities will stay in place up through November 11th of 2023. Likewise, ARPA SPAs, which did authorize, for example, coverage of some of our COVID treatments that were authorized under an emergency use agreement, as well as some of our COVID tests. This requirement will stay in place for 1 year and 1 quarter after the end of the public health emergency. The purpose of this, for example, as I mentioned, many of the medicines that we've used as part of our COVID treatment strategies and even some of our testing was approved quickly underneath an emergency use authorization. This extension of coverage does require states to continue to cover these products, even though they may not have full FDA approval yet. So it allows the companies to seek full FDA authorization in this duration of time, but people still have access to the tests and the treatments used to support individuals who may have COVID or may be testing for COVID. So the ARPA SPAs will last an additional year and a quarter. Last but not least, I wanted to highlight an option that Utah did opt into, which was this COVID-19 uninsured group, which allowed coverage for 15,000 individuals in our state who are currently enrolled in this to receive free testing and COVID treatments throughout the duration of the PHE. And so that they had access to services. While they may be uninsured, they had access to COVID-19 treatments and services. This coverage will terminate on the last day of the public health emergency, which is May 11th, 2023. So these letters have also been sent out to these individuals, so they're aware of their coverage termination ending on this date. And like I said, there are 15,000 and just a few extra individuals who do receive this benefit today. With that, that completes our update from the director's office today. I'll take any questions that you may have.
Thanks, Jen. Could you give us an example of, so a lot of insider baseball in terms of terminology, ARPA SPAs, Appendix K, maybe some terms that the general public's not familiar with, so some examples of what might be impacted there.
Yeah, that's great. So an example, like for example, under the ARPA SPA, was, for example, the medicines. So I mentioned that there were many medicines that were investigational that were being used to treat COVID. And as you know, we've worked with many of these different medicines came to market very quickly during the pandemic. And they were put out into the community and they kind of bypassed some of the regulatory standards that some of the medicines, for example, might be required to meet with regard to their FDA approval. The ARPA SPA gave our state authority, in fact, required states to cover and to provide access to these medicines, and also the flexibility to cover them, even though they weren't fully FDA approved. Okay, so under the Medicaid program, for example, there are certain rules and regulations that guide which medicines we're required to cover. And if it's not FDA approved, the Medicaid program isn't authorized to cover investigational treatments for the most part. So what this does is it gave us authority to be able to cover that so people had access.
And those are primarily medications to treat COVID-19.
That is right. Correct.
So
yeah.
People enrolled in general with some type of healthcare condition don't need to be worried that some drug that they have authorized today, unless it's generally for the treatment of COVID-19, are going to be losing access to any of their medications.
Yeah, that's correct. And this was also true for tests. Like many COVID tests, we know there were shortages on COVID tests or many new COVID tests coming to market, and it's the same type of coverage for COVID tests, for example. So, yep, thank you.
Appreciate the clarification there.
Yep, and then Appendix K, I'm going to lean into my colleagues just a little bit for some added detail. So, Brian, if you'd like to speak to the Appendix K flexibilities around caregiver supports and some of the ways that these helped support our population during the pandemic, would you? And Joe, would you mind explaining just a couple of the Appendix K benefits?
I'm happy to, and Joe can dive into deeper weeds than I can. But yeah, Appendix K is an emergency flexibility. So COVID-19 did grant the circumstance where we could get Appendix K flexibilities. One example that we did was raising rates. Typically, in order to raise rates under the waiver over a certain threshold requires a formal waiver amendment. Appendix K flexibilities allowed us to raise rates more quickly using emergency authority. So that's an easy example of the benefit of Appendix K flexibility. And Joe, if you have anything else you'd like to add.
So will those rates drop?
No, actually what we are doing is it gave us time to work through a formal waiver amendment. So we are actually right now working through both a medically complex and tech dependent waiver, and the rest of the waivers will also be updated before the Appendix K flexibility runs out. So it just grants us the time to go through the formal waiver amendment process. Yeah.
Okay, thank you. Any other questions from members of the committee or the public on the report? Okay, thank you very much. We appreciate the okay, another thank you coming in, but not a question. Great. All right, so next on our agenda, we have the eligibility and enrollment update, which I'm sure we're all anxious to hear from Jeff.
Good afternoon, everybody. I did give a presentation last time. It was the best presentation I never gave because my internet connection cut out, so I'm hoping to do better today. So with that, hopefully you're seeing a screen share, I hope shortly. There we go. All right, this is the familiar report. Hopefully you've seen a couple times now. This was passed out, I think, late this afternoon, and if you haven't got a copy of that, please let us know and we'll get this to you. This is our unwinding report for April. The thing that you all want to know is the thing I'm not going to be able to tell you today. You're going to want to know how many people are losing eligibility and where they might be going. When we meet next time, I'll be able to give you some of that good definition, but a little teaser for you here as we talk through this today. I will show you in a moment where you can get up-to-the-date information on May 8th when we post it out to the public. So I'll show you where that's going to be. Let me start by showing you how many people, this is as of March, were being held open by the state of Utah. So we have 531,723 individuals, the most ever on Medicaid in the state of Utah. And of those, about 273,000 were being held open artificially. We had all sorts of creative ways to keep those open in the system so that people could access benefits during the public health emergency. These numbers are actually derived from what we call the Kaiser report. It's a fun name for that. It's the report that you see each and every time we get together in this meeting and we show you what the enrollment looks like. You should expect these numbers to be slightly different. They'll be very, very close to this, but slightly different, as not all of these cases will be reviewed. For example, Jen just mentioned we have some people that are receiving COVID-19, the COVID-19 uninsured group. There's around 15,600 people on that program that are not to be reviewed in this as part of this activity for the unwinding review. So these numbers will be slightly different, and we'll present those next time, and you'll see that change as we go forward. In this we give you a couple snippets here of what's happening in the world of the unwind. We have been now looking, DWS has been looking at cases now since March 1st, and has now worked through to today's date, 4/20, which is when we expect to see the first closures and transitions occur. So that's happening in the background as we're meeting right now, with the ability to send out notices to the folks that are being affected. So I use those words intentionally. Transitions means that someone might be moving from Medicaid to CHIP, for example, or moving from Medicaid to Medicaid, to a different program inside of Medicaid. Those things can occur, as well as people moving to the marketplace, to the federal exchange, or some that will be losing coverage if we have not been able to find them, get a hold of them, or they simply have not yet completed their renewal. So a lot of those changes you'll be seeing in the data that we present next time, but we'll show you where that data is today. And then I thought it was helpful to have this little snippet in here for you too. These little pieces under status, it talks about DWS started reviewing April cases for May benefits on March 1st. I think these dates are probably a little bit helpful to let you know who we're looking at and when we're looking at them. So for example, April 1st, the start of this month, we started looking at May cases, which are really June benefits that are going to be impacted. So that's why you see a little bit of that delay. Even though we've started looking at cases, you don't see that impact until a month or two later. And of course, starting the report I just mentioned on May 8th, we'll watch for that. I'll show you where that's going to be. And the next cases we will be looking at are really the July benefits starting on May 1st.
Hey, Jeff, do you want us to hold questions till the end?
I can stop right here for you.
Thanks. Hey, for those that you started with on March 1st that will see, well, that may drop off May 1st, of those, plus or minus 25,000 that you're looking at, do we know how many were actually reviewed? How many were approved or not approved? Or are there still, how many are still hanging out there? And are they still working those, or have they moved on to April or June, if that makes sense?
Right away with the $1 million question. That's the question I'm unfortunately not able to answer yet. That data, like I say, that's happening in the background. If this meeting were tomorrow, we'd have at least preliminary data to be able to share with you. It just happens to be that we're at 10-day notice today. So we're letting folks know that batch job should have run last night. The data will be forthcoming here very shortly. I'm going to show you just a moment. As a matter of fact, that's a great segue. Let me show you to the next page here. Thanks. Which is, thank you for your question, by the way. The next page here is our unwinding website. And I think Jen dropped that in the chat. If not, we can certainly do that. This is medicaid.utah.gov/unwinding. And you may have come here before, but I want to show you the items that both Jen mentioned and where this data is to be found. So once arriving on this page, it's a lot of helpful government-looking information and historical information about what's occurring. If you scroll with me down just a little bit, you'll find these links for resources. Jen was just mentioning a moment ago the PHE Unwinding Benefit Flexibilities, which is on the left under Provider and Partner Communication. That's the right, isn't it? On the right. On the left, though, you will find, and we've kept this link hopefully at the bottom for everybody, to see the Unwinding Eligibility Dashboard. That's where we're going to go in just a moment. But before I do, we thought it might be helpful to show that there is more information if you scroll just a little bit more. This is the calendar of events that shows what's occurring and when it's occurring. And what we're talking about here, here's where we find ourselves between April 1 and April 30th, trying to figure out what does this mean? How many transfers are going to the federal marketplace? When will incomplete reviews close, et cetera? Well, the answer is April 30th, and we're just about on that date. And like you're hearing from me now, we're getting just that preliminary information, we hope, shortly. And then this pattern will continue at the end of each month going forward. You should expect to see those transitions occurring in the Medicaid eligibility world as people are sorted through. Some have likened this to the sorting hat in Harry Potter, as we put that hat on, figure out where the person should be, and get them to move along after 3 years now of being essentially held in one place. So that is what is shown down below with a little bit more information on the federal marketplace, et cetera, if you wanted to see that. If you were to click this link here today, it will take you to the Unwinding Eligibility Dashboard, which I'm going to just magically do for you right now. Look at that magic. This is the data. This is publicly accessible today. Again, I showed you where that link is, but we can also drop this link if that's helpful into the chat. This will show you the data as we know it for right now. I'll just orient you a little bit on this today, just quickly go through, and then we'll focus next time as we get together specifically on the next tab, which is the review outcomes. That's a fun name for where did everybody go? And that's what people want to see, I think. So again, this is repeating a little bit of how many folks have been held open. It's similar to the other charts, just a line instead of the bar graph you've seen before in both cases and individuals. The tabs are located here in this purple bar. And importantly, you can see the last time we updated this data. The last time was on April 10th. The next refresh is on May 8th. That's the same day that we're sharing our information, the state's information, with CMS. So you're getting information live as fast as we can get it out to you and share with everybody. And if you get curious on any of these, you can hover over these lines. You can see all sorts of information based on the months if you hover over those lines, if you want to get more detail there. And we tried to put definitions out to the side if those were pertinent to the graph we're showing you. I'm going to, again, just move forward through some of these. And of course, if you have questions, we'll take those as well. We won't spend a lot of time here today because it's not going to be terribly interesting to you yet, but it will be. This is where we talk about what's happening to cases that are on a regular review cycle versus those cases that were held open, and what happened with everybody altogether. You're going to see in the future cases that were not closed. That's a fun term for they stayed with us. They stayed with us on Medicaid. That's where they belong, maybe in a different program, but they stayed with us in Medicaid or CHIP. If you see yellow, or when you see yellow start to appear, that means those cases went to the marketplace. And you'll see a little bit of that activity in the past. Those cases tend to be CHIP cases that are ending their eligibility in the past that have moved on to the marketplace. And then most importantly, I think for a lot of folks, is the purple color here, which is going to be those not sent to the marketplace. In other words, we did not take a look at that person. We were unable to do so. Either their review was not completed, their address was wrong. It could be all sorts of reasons in there, but we were not able as a state to look at that particular case and send them either keep them with us or send them to the exchange. So those are the colors to be watching for next time. And I would assume that more detail will be wanted on that, and we can certainly delve into more detail as that comes up. One key factor that was asked for, which falls right along with these review outcomes, is who's moving to CHIP. We just came out of the MCAC meeting a few moments ago. Thanks for those that enjoyed this twice. But we will try to track how many kids are moving from Medicaid to CHIP. These numbers are, and these graphs are dynamic. They'll actually expand and contract as the data changes here. Very few kids, as you can see, moving from Medicaid to CHIP in the current environment. This number will start to move drastically once we stop keeping the kids on Medicaid that should have moved naturally to the CHIP program. Jumping to members, there are a couple things we thought we'd want to watch during all of this process. One of those is, are we closing anyone that we shouldn't be? The thought behind this is, if somebody closes inappropriately, it's more work for DWS, it's more work for the person, certainly, and it causes a bare period of time where they're not covered. This particular chart is meant to try and track a question that was asked in this very meeting several months ago, which was, how do you know who is new to Medicaid and how do you know who's just returning? So we defined what that means. New to us means we have not seen this person in the last 90 days. It doesn't mean we've never seen them. It just means in the last 90 days, we have not seen this person before. And you can see those numbers, and this is live data that you can see over the past several months. And then returning members, these would be folks that we have seen in the past 90 days. If this lower graph starts to tick up very, very high, that means that something's wrong. We're closing cases for whatever reason and not getting the people or continuing the people's eligibility when they truly were eligible. Instead, they were closed for some period of time up to 90 days, and then we reopened them. So that's a graph that we're going to be watching very closely as we move forward. There's a lot of other data out here. We're not going to go through every chart, but there's a lot of data on applications received by DWS. Fair hearings might be something that people will be interested in if there are more hearings being called. We have this, I like to call the canary in the mine graph. This is one that shows presumptive eligibility in the state of Utah. These numbers have been historic lows lately because a lot of people still have their Medicaid from 3 years ago. If we're closing people inappropriately, they tend to show back up in the hospitals and back up in the clinics where we have staff that will help get them eligible for Medicaid once again under presumptive eligibility. So if this graph goes up, it again might indicate that we are closing the wrong folks or that something is wrong with the process. And then finally, one that was asked for statutorily was the call volume. This is the workforce service call volume, shows their monthly call volume and total calls, shows their average wait time, and then the call abandonment rate all on one screen for you to peruse. And again, you can hover over any of these bars on any of the graphs I've shown you today to get the detail that you're looking for. So with all of that, let me pause and see what questions we have brought up. Oh, a few. Wow. Like right away. I think Brandon Hendrickson's first, at least on my list that I can see.
Hey, thanks, Jeff. Yeah, I just had one question, and maybe you can confirm this to me. I know term letters went out yesterday to members. Do we know if all the members that got terminated, if they had exhausted the ex parte process to see if they were potentially still eligible? And is there any reporting on that for the members that are being termed on this dashboard? I've kind of tried to look around. I haven't been able to find anything.
Great question. Let me explain a little bit. When you mentioned ex parte, thank you for the question. When you mention ex parte, that is without the person there. So this is a review that Workforce Services, that they grab a case, and they do this with every case is the answer. So we grab each case. We try to pull any data source that we have available to us at the state of Utah. So it could be wage data information that Workforce Services actually creates. It could be unemployment information. It could be information that we have through other sources that pull that together. If we're able to, we will then renew the case based on that information. Nobody can be denied on that information. So if the information indicates, hey, this doesn't seem to add up, or the person looks like they're ineligible, that person then falls to a regular review, which is either through paper on a pre-populated review form, or if they have opted to online services, they go through the MyCase product to then complete a review that way. So to answer your question, each person was attempted, that is closing in particular, an ex parte was attempted on that person first, because that's how the process has to work. So that would have occurred. And that data is actually, we don't have it captured in the data I've showed you today, because that was a later breaking figure that wasn't developed at the time. But that information is shared publicly with CMS and part of the data that Utah will submit as we go forward on May 8th. Great question.
Thanks, Jeff.
Next, I have Stephanie Burden. Hi, Stephanie.
Hey, Jeff. Thank you for all of this and appreciate all of the work y'all are doing. I'm curious about like are y'all measuring like outreach efforts, or like is there any kind of like as far as like our providers getting out, like are they posting flyers? Like is there anything about just like what outreach is being done that is like also being tracked, or is that kind of just scattered throughout whoever is working on like connecting with members?
Sure. A difficult question to answer about the best I can. We don't have any tracking per se that's occurring with providers and what they may or may not post in the offices. What we did do was we tried to put out some information that providers can put out there. I'm going to switch back to this tab. This is, again, the unwinding. I'll go to the top. This is the unwinding website. And again, on the, I think, right-hand side, if I get those mixed up again, this is the right. You'll see that we have some general information, some toolkits as well here. These toolkits will give the kind of flyers that someone could post and can. And to answer your question, we have had several providers that have contacted us that are interested in helping with this effort. But we don't, of course, we don't mandate that they do this, but they certainly can. And many do want to be part of that activity. But as far as the outreach goes, oddly enough, we have an outreach campaign going on right now. It's really focused on children. It's both CHIP and Medicaid and trying to enroll more kids. So that's happening in the background as this process goes forward. We did have a presentation in the CHIP Hack earlier talking about some of those billboards that have been done, as well as radio spots and some online activities as well. So that is occurring in the background as far as marketing, meaning enroll. This is great. As far as communication to members, that's right down the middle of the page here. These are all the letters that we have attempted to reach out to members and let them know what's happening so they have a good feel for what's going on. We are working with health plans in the background to have them also reach out so that if someone, so if Workforce Services misses the case or two because the address wasn't up to date, maybe the health plan, who gets a list of those at the end of the month, will have a chance to find them, locate them, and get them back over to us. So we've tried to think through those things. We're certainly open to more ideas, and we'll try them as we go forward. And hopefully we're nimble enough to make those kind of changes and adapt to those things as we go forward as well.
Can I share a couple ideas I've heard from other members? Just like on a positive note, I got a text from a member who sent me like a screenshot of her email. Like there was an ad promoted in her Gmail account of like renew your Medicaid. Anyways, and whenever she clicked on it, it was from the, it went to the Medicaid Utah.gov. And anyway, she loved that. So that was a good thing that I heard. But a couple things of surprises of just like not seeing, like, so schools, like I've heard that it would be helpful for Medicaid beneficiaries if like they got information from the school. So targeting like kids on reduced lunch, I don't know, targeting kids on free and reduced lunch maybe, or something like that. And then public transportation, which like I take, and I've asked others who also take it if they've seen any advertising on public transportation, and I haven't seen anything yet, and they haven't either. So I don't know if that's like something that's on the campaign efforts, but maybe that would be a good place to put some stuff. And then I'm not sure what the plan, I've heard, I know that they have done some outreach voicemails and text messages and things like that. But if there are any efforts with plans where you all know the providers that you, like if y'all have like, I don't know, like a list of like doctors' offices or hospitals or places where there's like a lot of Medicaid traffic, I would encourage you to reach out to them and ask them to put things up. I haven't seen any flyers in any offices or healthcare entity yet. And I do think at least, I think one perspective is that some of us might feel comfortable talking to like, the nurse case manager or something while we're there, if we did see something and then it would allow us to ask another question or something like that. So if that's something that the plans were able to do, I think that would be really helpful to get to members more. But yeah, schools, the actual healthcare setting, and then public transportation are just like, but I have heard that some, like there are people who've gotten like messages and seen like ads pop up and stuff like that. So appreciate the work that is being done, but maybe those are some other suggestions that I would recommend.
So first of all, thank you for those suggestions. We'll take each under advisement. Those are some good ideas. And then I did neglect to mention that there's a national campaign, because this is happening across all states right now. So CMS did inform us that they're doing some activity in our region, which would include Utah, of course. And that's where any ads you're seeing right now, they're talking about renewing coverage, et cetera, are likely coming either from the health plans if they're doing something on their own, or it's coming from CMS at the national level. So that's probably what your friend saw. But thank you for that. Good ideas. And then next I had Rachel Craig, I think.
Hey,
Rachel.
so first of all, thank you for all this. The information and just like the availability of the information has made this extremely, extremely easy for me to get this information to the 13 health center organizations that I report to. So that's really, I just can't thank you enough, because I have talked with my national association and I know that this is not the case in many other states. So I feel very thankful. I have a question that you might be able to answer, but I sense that Maurice might actually be able to answer it as well. One of our outreach and enrollment staff, they asked if there's a way for members to be able to track the progress of their review, like, initiated, in review, and then like if there's like a tracking thing, like, I don't know, kind of like the Domino's pizza tracker. I'm sorry that I'm using that as a reference point right now, but I am. So I was just wondering if there's any way for them to do that. They wanted to know that, just to be aware of like what their like members are seeing.
I'll take the first stab, then Maurice, you can chime in what you'd like to as well. So we do have a notice committee that's spurred off of this group at some point about a year or so ago. And that actually came up in that group as well as an idea of how do you show that. And there's some technical difficulties on how that may or may not be able to occur, but it is something that we're actually interested in doing. There's another group, it's called the Citizen Portal, which is, it's the ability for essentially anyone in Utah to be able to go and do any online activity. And It's a group that's reached out to us that is mandated actually to work with Medicaid to facilitate Medicaid applications, et cetera. And they had the very same question. Is there some way to show a tracking type environment? So you're not the first or the last probably to ask about that. I think that that's something that we certainly should consider and try and find a way to do. It's a new feature that we could maybe incorporate into maybe our MyCase project or something like that. But I'll turn that to Marissa and see if you have any ideas.
Sure. So I believe we can talk about what currently exists and how we can enhance this further. The MyCase product itself, for those of you that are familiar with it, gives you or allows you a couple of things that I think can be today used as a tracker. So you can look at your notices that have been sent to you. So if a request for a review has been mailed to you or a review has been pre-populated and mailed to you, that would be one thing you can track. Today you can also track any of the documents that you may have turned in to us. We've on April 1st, we've launched a new feature in which you can take a picture of any document, you can upload it to us. That would be including the reviews, although there's a better way to submit a review online. So I believe there's some tracking that currently exists. If people want to have us give a presentation about how to best utilize MyCase to do that, we can do that on an individual basis. So just feel free to reach out to me if you'd like to do that. And if you have any ideas about how we can do that even better to enhance that, we continue working on enhancing MyCase to have it a preferred method of contact for all of our customers to reach out to us. And if there's ways where we can better and further improve it to provide that type of a tracker, because honestly, what you're probably looking for is, has the review been requested? Has the pre-populated review been mailed out? Have we received the documentation? Is it currently being processed? And have I been recertified, right? I think you can draw those conclusions from MyCase currently. However, if there's other things that we can explore, we're more than willing to do that.
Awesome. Thank you. That's helpful. And then I just want, this isn't really a question, but I think this is a good place to plug this, like a group, just so everyone's aware. Utah does have a program called the Health Insurance Premium Support Program, otherwise known as HIPS, which provides premium payment assistance with marketplace plans. If someone enrolls in a silver level plan, you have to be, assistance is available for like households below 400% FPL, and it usually gets your premiums down quite a bit. So if you know someone that, you know, is losing Medicaid coverage and does need to transfer into a marketplace plan and is worried about paying premiums, I will drop some of the information in the chat right now about the HIPS program. It is administered by Ouch, but it is available to, you know, anyone. They don't have to be a health center patient or anything like that. So just wanted to make people aware of that as we're going to see people start transferring onto plans. And because as we know, marketplace plans are quite a bit more expensive. So yeah, I'll drop that. And if you have any questions, you can reach out to me about it. I will say that the site needs to be updated. This was an oversight on my part. I actually just saw it. It just needs to be updated because it refers to open enrollment, but that will be done by next week.
Excellent. I did notice there was a question in the chat from Russell, and so this is for you, just for you, Russell. The data is so live, and I guess we'll take your input on how this works for you. Because this data was posted on April 10th this year, what you're seeing, sorry, let me review your question. Your question was, the DWS monthly call volume, you would expect it to be roughly 2/3 of March, since we are 2/3 of the way of April. Why is the April call volume so low? The answer is, as we posted this data, this was actual live data showing the number of calls that had come in between 4/1 and 4/10. So this is not a complete picture on this last column for the month of April. You'll see that in the next iteration. We debated whether we should show that month or not show that month. We figured we would just show from the point in time that we publish to the point in time we publish again. So that's why that looks a little bit different on this graph. Hope that answers your question.
Can I ask a follow-up question?
Of course.
So the same question would still remain. Then you could be 1/3 of the March volume of the March, and we're trending a lot lower, which seems like intuitively you'd have more people calling in with questions. I just wondered if there's anything that you know what's going on as far as why there's less calls, because that's what it appears to be showing.
I think if I can just jump in,
Sure, please.
My understanding of the data is we pull it weekly. So there was only one full week that happened. So even though Jeff was correct, we pulled it as of April 10th, but it had just April 3rd through April 10th. We may have actually ended up counting the previous first few days of April in the previous week. They're lumped a week at a time. So that really only represents 1 week of a month's total. So it's probably more accurate to think of it as 1/4 of March, in which case it looks about that much to me.
Thanks.
Excellent questions. And we do appreciate you looking at the data. And if there are improvements you'd like to see in these graphs or detail over time, please reach out to us and let us know. We'd like to make sure this is informative and helpful to you. Are there any other questions? I didn't see any other. Michael Hales, we know him.
Well, thank you for the presentation and answering all those questions. I think helpful. Given that the time of our meeting is unfortunate in that we don't have any information, could you send us a report next Monday to the MAC and the people that participate on the email distribution list, the email listserv, just in terms of what your data ended up being that you find after you've got all the results from the closures that will take effect May 1st, just so we don't have to wait until May 18th to get the information.
Well, I think the CHIP Act and the MAC are very much in sync today. That same request was made earlier today in the CHIP Act meeting. So I'll work with the folks in Medicaid here. We'll see if we can get something together for you for early next week.
Yeah, and so thank you. It doesn't need to be the same complexity that you've got with all your reports, but even if we could just have some preliminary data in terms of how many people were reviewed, how many were closed, and any observations about where they ended up on some of the information you provided.
Excellent. We'll strive to do exactly that. Thank you.
Okay.
I'll turn the time back to you.
Well, thank you again for the presentation. That brings us to our committee member updates, final agenda item. First, we're going to have a presentation from Jennifer Marchant, and then we'll open it up to other members of the committee who would like to make any comments or observations for consideration from the MAC and advise the department on. So Jennifer.
Yes, can you hear me?
Yes, we can. Thank you.
Oh, wonderful. Okay. Thank you, Michael. My name is Jennifer Marchant. I'm a CPSS, Certified Peer Support Specialist through the Office of Substance Use and Mental Health. I am also a volunteer behavioral health advocate and the behavioral health rep for the MAC group. I've been asked to speak today about the behavioral and mental health Medicaid bills during the 2020-23 legislative session. Now, I will note that I am not in any way a legal expert. I am a humble grassroots advocate, and every year for the legislative session, various organizations come together to support legislation in mental health. We contact our legislatures and inform and educate them about the community impact of various forms of mental health legislation. So I will go ahead and mention some of these different organizations since they are the information sources for my presentation. Of course, there's the legislature's website, leutah.gov. The USAVE group, also known as Utah Substance Use and Mental Health Advisory Council. There is AARP, there is NAMI, and UHPP, which is also known as Utah Health Policy Project. So the majority bills I'm discussing have passed. Later, if I have time, I may mention one or two bills that haven't passed or have been put on hold. But I'll provide time for group comments or questions later. I'm going to do a very basic run through, and many others in the MAC group may or will have better or additional information to add. So the first one that I have up here, Jennifer Strohecker touched on it a little bit. It is Senate Bill 19. The governor signed into law on March 15. It is the Medicaid Dental Waiver Amendment. This bill requires the Department of Health and Human Services to request authorization to provide dental services to Medicaid eligible adults who are not already eligible for dental services. To my understanding, the department provides dental services to blind and disabled individuals who are 18 years and older. Once approved, it looks like coming up here on May 3rd, the department will provide dental services to an individual who, one, qualifies for the Health Coverage Improvement Program, two, is receiving treatment in a substance use treatment program, and or three, who is an aged individual. These services shall be provided through the University of Utah School of Dentistry and their associated network. Before I move on to the next one, I first wanted to thank AARP and the Utah Health Policy Project for monitoring this. Are there any questions on this Senate Bill 19? Okay, I'll just move on to the next one quickly. This one is Senate Bill 217. And I think Jeff Nelson touched on this one just a little bit earlier, the Children's Health Coverage Amendments. This bill creates alternative eligibility requirements for the CHIP program. The bill modifies definitions and creates a waiting list for applicants eligible under these alternative eligibility requirements. It creates the quote, Alternative Eligibility Expendable Revenue Fund, closed quote, through the Department of Health and Human Services. A traditionally eligible child may enroll in the program if the child does not have access to or coverage under other health insurance and or is ineligible for Medicaid benefits. A child who qualifies for enrollment in the program may not be denied enrollment due to a diagnosis or pre-existing condition. If funding is available, it will implement a simplified enrollment and renewal process. The department may create a waiting list for enrollment if eligible applicants exceeds the funds available. My thanks to UHPP for monitoring this. Any questions before I move on to the next one? I have up next Senate Bill 106. This is the Caregiver Compensation Amendment. This bill addresses reimbursement for certain personal care services under Medicaid. It directs the Department of Health and Human Services to apply for an amendment to an existing waiver to the state Medicaid plan to implement a program to reimburse a parent or guardian who provides extraordinary personal care services to a waiver enrollee. Money appropriated in this bill is for this year, fiscal year 2023, and falls under the Department of Health and Human Services. This is a mouthful. Quote, long-term services and support community support waiver services, close quote, for $1,734,500. This bill also appropriates in fiscal year 2024 for the same amount. I'll note in the language of the bill, it states, existing home and community-based services waiver means a waiver in the state that serves an individual, one, with an acquired brain injury, two, with an intellectual or physical disability, or three, who is 65 years or older. My thanks to AARP and UHPP for following this. Any questions on Senate Bill 106? All right, I was going to touch on Senate Bill 133, but Laura Belgique, Stephanie Burdick, and Jennifer Strohecker did an amazing job with covering everything on that. That was called the Modifications to Medicaid Coverage, more specifically somewhat known as the Pregnancy and Postpartum Medicaid Coverage Amendment. So really, all three of them covered everything that I was going to touch on in this presentation. So I'll just move on to the next one here. This one is House Bill 248. It is mental health services for adults. This bill amends provisions related to mental health services for adults. It requires the Department of Health and Human Services to create a long-term, statewide, assertive community treatment, also known as ACT or ACT, team plan. It modifies a grant program for the development of ACT teams and requires the department to report to the Health and Human Services Interim Committee regarding the long-term statewide ACT team plan and ACT team grant program. The reason I bring this up is that it mentions Medicaid reimbursement for services provided by ACT teams. Amongst other duties, ACT teams help identify gaps in housing needs for individuals served by ACT teams and how to ensure individuals served by ACT teams can secure and maintain housing. They coordinate with local homeless councils and criminal justice coordinating councils. Also, they provide clinical support, case management, peer support, employment support, and other services. My thanks to the USAVE group and UHPP for following this so closely during the session. Last but not least, I have House Bill 78. And this one is very important to me. This one is the Behavioral Health Treatment Access Amendment. As some members of the MCAC group may remember, last September, I gave a presentation about concerns with client care in behavioral health clinical settings, and that client can be a medical doctor. This included a tragic event during the pandemic in which a medical doctor at Riverton Hospital took his own life, in part because of issues in behavioral health access and privacy issues. He was only allowed to access mental health care in his own network. And this created a dilemma in that the individuals in his network were his coworkers. And there were serious privacy and professional issues at stake here. In seeking or receiving services from his coworkers, he risked stigma and had a fear of losing his job. Not to mention he would have had to work with the individuals who would be his mental health providers. The language in this bill states, beginning January 1st of 2024, a health benefit plan that offers coverage for mental health treatment shall, upon request of a health benefit plan enrollee who is employed as a health care provider, will offer a single case agreement that allows the enrollee to receive covered mental health treatment from an out-of-network mental health provider selected by the enrollee. The language states here, a single case agreement shall reimburse the out-of-network mental health provider for the covered mental health treatment at the equivalent out-of-network rate set by the health benefit plan. The network providers do not provide the covered mental health treatment at the location where the enrollee works as a healthcare provider. The location where an enrollee works includes all the locations or facilities of the enrollee's employer. So that could include a clinic in Riverton or Sugar House, Park City, Farmington, wherever those may be. I want to give my thanks to the USAVE group, Utah Health Policy Project, and especially to Representative Steve Eliason and Dr. Jennifer Plum for sponsoring this bill. It removes another barrier to mental health treatment, especially for the providers who have given so much during this pandemic and who will be continuing to give care in the future. I'll close this up and thank you so very much for your time. Any questions? Okay.
Thank you, Jennifer. Appreciate your summary of some of those pieces of legislation as they impacted the behavioral health community. Again, this is time for committee members to bring up issues that they would like to present to the MAC or discuss, raises issues or concerns for consideration. So I'll just open it up for general feedback or comment if any of the MAC members would like to raise an issue for discussion.
I have a question. I know that we talked about this several months ago, but I'm curious about the UTA pass and if there's any updates about like how it's being utilized, and then also how a member can get one if they didn't get one in the mail, or if they were like, I can't remember if there was only select members that received them, but I was asked where someone could find one if they didn't receive one in the mail and they are a Medicaid recipient.
Okay, thanks, Jen, or someone on your staff. Could you answer that for Stephanie, please?
Absolutely. So Stephanie, regarding UTA and someone getting a pass, first, individual can go into their My Benefits within their login, and there's actually a questionnaire built inside that tool that will kind of screen if the person's eligible to get the UTA pass. And that's probably the fastest pathway with regard to just walking through. I think there's like 3 questions, right, that an individual needs to answer. And then other pathway would be calling a health program representative. So you can call a Medicaid HPR as well. That could assist the member with getting a UTA pass. With regard to utilization, I saw Brian pop on here. I personally haven't looked at these numbers in a while. I know we are collecting those, and we've been looking at use and trends and just look at like average utilization per month. But I don't know if maybe that's something we can bring back for you, or just supply for you, just to walk through what that looks like now, and how people are using the pass. So we'd be happy to gather that and bring it back for presentation.
Thanks, Jen.
I'm sorry, is that just through your Utah ID or through your MyCase, or?
Underneath the, it's under the My Benefits portal.
Thank you.
Yeah. Do you need the hyperlink for that?
Sure, that'd be great.
Okay, hold on. Thank you, Brian.
Great. Thank you, Stephanie, for the question and the response, and we'll plan to put that on an upcoming agenda. Okay, other comments, concerns, questions? All right, and then let's just ask if there are any other comments related to the public hearing on the demonstration waiver for the extended eligibility postpartum. Okay, well, then we'll go ahead and conclude our meeting. Thank you, everyone, for your participation. Thanks to the department for all of the presentation of information and all of the support for the Medicaid patients, enrollees, members, and congratulations on the PRISM system and the success you're experiencing. Again, a lot of updates and modifications, we realize, but still a lot of success stories there in bringing up a new, very complicated system. So we compliment you and your responsiveness on trying to address issues as they come up there as well. And then a reminder that next month is our public hearing. We'll be meeting at 4 o'clock instead of 2 o'clock. So we don't want you getting on at 2 o'clock and figuring nobody's here. Just a reminder of that time change. That's the only time during any of our meetings that we alter it from 2 o'clock, and that'll be next month. And if you want to comment or make a presentation, please reach out to Sharon so she can put you on the agenda and we can have a sense of how many presentations we'll have so we can allocate time appropriately. Okay, with that, we will finish our meeting. And again, thanks to everyone for your time today, and we'll see you next month.
Thank you.
Thank you.
Thank you.
Bye-bye. Thank you.